We're discussing indications, investigations which help the surgeon for a safe aortic valve replacement and some complications along with operative steps. Coming to this bibliography, Kirklin has given excellent operative instructions for aortic valve. These 4 books need to be 3 numbers. Severe aortic stenosis, the mean gradient, which is the most robust one, it should be greater than 40 mmHg. Peak velocity should be greater than 4 millimeters per second, and valve area should be less than 1 centimeter square. 40, 4 and 1. Remaining indications are complicated. You don't need to stress on that. Coming to the investigations, the backbone investigation is echocardiography to assess the severity of aortic stenosis, assessment of LV systolic and diastolic function, LV wall thickness, chamber size, quantification of associated aortic regurgitation, estimation of PA pressures, measurement of aortic root diameters, and assessment of associated root sclerosis. These are some, the most important thing in which you have to concentrate as a surgeon are 3 diameters. This is the diameter at the sinus of Valsalva. This is the diameter at the level of the annulus. And this is the diameter at the level of ascending aorta. And this is how your valve should look after excision, not before excision. The most important things. The most important thing is this bundle, this anterior mitral leaflet, which you are more prone to injure when you are doing non-coronary cusp decalcification. And usually when you see the valve, it doesn't look as clean as this, but you have to strive to make it clean like this. Coming to the operation, the main thing, usually you do a standard median sternotomy when you are a novice. You harvest the pericardial patch. I will tell you why do you need to harvest it before. And cardiopulmonary bypass is instituted using high aortic cannulation and 2-stage venous cannulation, and always keep a right superior pulmonary vein vent. Antegrade cardioplegia is infused into the aortic root after aorta is clamped, provided there is no aortic regurgitation. If there is aortic regurgitation, sometimes you need to open the aorta directly to give ostial cardioplegia. This is high aortic cannulation, where the aorta is cannulated just beyond the origin of, just in front of the origin of the innominate artery. This is a diagram showing the venous cannulation, 2-stage venous cannulation, and this is how the venting is done through the right superior pulmonary vein. And coming to the exposure, this is a diagram from Kirklin. Initially, you don't need to give this much bigger incision. You need to be aware of the origin of the right coronary artery, because that is where you give the incision about 15 mm downstream to the origin of the right coronary artery. This fat needs to be retracted. This epicardial fat needs to be retracted before you give the incision. Usually the thing is you give a small incision in this area, inspect the anatomy, and you can extend it sometimes obliquely like this, or you can go transversely like this. Oblique incision is useful in small aortic roots. This is the oblique incision. You start the incision in the medial aspect of the ascending aorta. You bring it to about 10 mm, inspect it. Beware, this incision should not go more towards, it should start 10 mm before the origin of the non-coronary sinus. Otherwise, it's difficult to close this aorta when you have completed the aortic valve replacement. Coming to the removal of the aortic valve, initially the thing is, when you are starting off, you need to keep a sponge, packed sponge inside the aortic valve, and you should be careful about this sponge. You should be removing it after you do the decalcification. Coming to the mode of decalcification, Kirkland says you need to start decalcification at the area just in the middle of the right coronary cusp, because this is the area which is comparatively free of calcification. You start here at the free edge and slightly and go towards the left coronary commissure. You end here. After that, you start from here and you go towards the non-coronary commissure and end here. This area is prone to this commissural area between the left coronary sinus and the non-coronary sinus is prone to rupture. That's why it's better you approach this area from both sides. This is one more diagram which shows the second part. Now you are approaching the non-coronary. You are taking off the non-coronary cusp and you are removing this part. And this is one instrument which is the pituitary wronger, which is used to decalcify. When you are doing these are the instruments which are used. These are all pituitary wrongers. These are retractors. This is a leaflet. These are leaflet retractors. These are normal retractors. This is an endarterectomy. This is a Watson chain. This is one more aortic retractor. These instruments should be there when you are doing an aortic valve replacement. This happens when you are overzealous in your removal, in your decalcification of the right coronary cusp, of the non-coronary cusp. When you are trying to remove this calcium, you can injure the anterior mitral leaflet. When you injure the anterior mitral leaflet at this position, it's better you stop there, take a pledgeted suture like how you do in a aortic valve replacement, and seal the gap. This suture can again be used for when you are implanting the prosthetic valve. After the valve is excised, the bed is examined, any loose calcium particles are removed, the gauze is removed. You should not forget to remove it. After the LV vent is turned off, the LV cavity is irrigated, aspirated, and the LV vent is again activated. Now the sequence of suturing. Then you size the aortic valve with the veins of a sizer, and you take 3 simple sutures in the area of the commissures. The thing is, the aortic annulus is not a planar structure. When you are trying to take these sutures, sometimes when you are trying to take this suture, you need not retract. If you retract the area of the aortic of the aortotomy here, you cannot see this. That's why it's better to handle with 2 forceps here, so that you can see this commissure. These 2 sutures can be taken forehand or backhand depending upon your preference. And these are the modes of suturing. These is how sutures are used. A shows standard interrupted sutures with pledgets in the supraannular position. C you use when you are seating, when you are trying to when you are trying to seat a valve in a small annulus. This figure of 8 sutures when this non-coronary cusp is injured are not being used now, but you need to know about them. Sequence of suturing. Kirkland says you need to initially start the suturing in the left coronary cusp. After that the non-coronary cusp or the sequence of suture tying. After you take the sutures, this is how the sutures are tied. Initially, there is a basis behind it, which is given in Baumgartner. Initially, the left coronary cusp sutures are tied, After that, the region of the right coronary sinus. After that, in the region of the non-coronary sinus. If the suture breaks in the region of the left or the non-coronary sinus, the valve can be lifted and another stitch can be placed. If the suture breaks in the region of the right coronary cusp, pledgeted sutures can be taken from outside the aorta through the sewing ring. These can't be done in the region of the right and the left coronary cusp. This is the reason for the sequence of suture tying. And suture tying needs to be done in this way, in parallel to the sewing ring. Because if you try this way, you are prone to injure the leaflets, you are prone to injure your finger also. And coming to the end step, but this is the most exhaustive step, aortotomy closure. This is initiated with 4-0-proline in a double layer at each end of the incision. The protective step is, you see here, we are taking a segment of the normal aorta in order to reinforce the aortotomy. And this is done ideally in situations when the aortotomy is not so retracted. You do the aortotomy from both ends, and you suture, and you tie the suture at the anterior end of the incision. This is the use of the pericardial patch, which I told when you are harvesting initially. Sometimes the thing is this in oblique aortotomy incision, when you close it primarily, there is some disruption of the sinotubular junction. That's why it's better you use a patch, pericardial patch. Usually tanned pericardial patch is useful in these situations. Dearing is the most important step in aortic valve replacement, because the heart itself is hypertrophied. Any small insult to it, it's not going to forgive you. Just prior to aortotomy closure, the RSPV vent is turned off. In the head and down position, the heart is temporarily filled, the lungs are bagged. The right coronary, because it's in the highest position, it's occluded the finger. The CPB flows are temporarily kept down, cross clamp is released. Simultaneously, both vents are restarted, and CPB flows are backed up slowly. After that, you remove your finger from the right coronary ostium. Patient is rewarmed and slowly weaned off bypass. Coming to the complications, the dreaded complication of aortic valve replacement is bleeding, which can be dealt by closure of the aortotomy securely with a pericardial patch or taking a normal aorta. Complete heart block is one of the complications when you are doing an overzealous decalcification, or sometimes calcium is there and you have to remove it by otherwise you have insecure processes. It can't be avoided sometimes. That's why it's better you come off with the 2 pacing wires. Neurological deficits in aortic valve replacement are because of retained calcium particles or inadequate deairing. This is the diagram which shows this suture taking injuring the bundle. And your job doesn't end after doing the surgery. You have to stress some special features of post-operative care. In a patient of severe aortic stenosis, about 30% of the cardiac output is by the atrial kick. That's why you should aim for synchronous atrial and ventricular contractions. AF, unlike in a mitral surgeries, is not tolerated and you should have a low saturation for AF conversion. Adequate preload, unlike in a normal heart, because the LV is hypertrophied, and you should have an adequate filling pressure, and there should be control of systolic hypertension in the initial 3 hours to reduce myocardial oxygen demand and to protect the aortic suture lines. Thank you.
That's very good. Just a few comments. I think you already mentioned what we need to remember is that aortic annulus is not a round this thing. It's like we need to remember the commissures are going up. A few things is I always prefer the oblique incision, because sometimes what you find The sinotubular junction is narrow and your valve might be difficult if you take a horizontal incision above the sinotubular junction. In those situations, if you take a oblique incision, the actual sinuses are much wider. So you're right that we should stop way before the annulus. Your incision should stop before the annulus, and in those situations, it will not be difficult to close the aortotomy. And decalcification, you have to be thorough. There is no question about it. And whenever you have this thing defect, you have said you should repair it then and there. Otherwise, it will come back to bite you. But I think you've covered most of the points. Patient, we should all get patients evaluated according to TAVI protocol, and we should all get TAVI savvy, if I can say that. Okay, we should all know that language and the measurements and all those things. Although this topic was about surgical aortic valve replacement, we should be looking at TAVI as well, because the competition is really behind us.
It's a very nice talk actually for a novice cardiac surgeon AVR, and I close aorta in single layer, so it's totally. But this is a nice this thing.
We used to close the aorta in a single layer as well, but our technique, our closure was not as good as yours. So we used to keep on getting into problems and taking repeated pleated sutures on the suture line. So that's why we converted it to 2 layers, one layer horizontal and the other over and over again. So that has also because we kept on damaging the aorta with repeated retractions. This is much more comfortable for us. One thing which Gopal always mentions that Verma sir operate before, he used to do the regular way quite beautifully. So I don't know why he switched to that. And one more thing which I wanted to mention was as a bailout when I was with Mishra sir, quite a few times we put simple sutures. One suture on the annulus and take it through the valve. And it is a very good bailout technique. As I said, better not get into it. Especially the newer surgeon should not get into any variations. I think simple everting mattress sutures and seating the valve comfortably. I think most of our patients are very small and they don't have ambitions to climb the Himalayas. So I think regular standard sized valves are quite good for us. I think so. Thank you, Ramakrishna. Wonderful presentation.
Thank you, sir.
Ramakrishna assisted 50 AVRs before he did one. I assisted 300 mitral valves before I did one.